So, good evening, everybody, and thank you so much for joining us tonight for our Piezo Wave Users Open Forum. Tonight, it's Dr. Lisa Mason. She owns the Florida Veterinary Rehab Center and runs the team, a big team. The team has grown, which I think is really exciting. I met her 5 years ago and it was a small team. And now we're up to 3 doctors. What do I counted on the website? 3 doctors, 4 rehab therapists, and 5 rehab assistants,
Yep,
et cetera,
always
et cetera.
waiting. So, yep. Always,
So
always in need of more. So if anybody wants a job in Florida, so let us know.
sunny Florida. For those of you who don't come on a regular basis, I do have the chat open, and I'm happy uh, to read questions that come from there. But our goal is to make this interactive for you guys to ask questions, um, and for everybody to learn from each other. So with that, I hand it over to Dr. Mason.
Thank you, Cindy. So, as Cindy said, I am in sunny Florida, in Central Florida. I am a standalone rehabilitation practitioner. I am certified in rehab, acupuncture, and pain management. I do quite a lot of sports medicine, and a lot of musculoskeletal ultrasound, which then leads us to lots of PRP injections or joint injections and Shockwave. So that is kind of leads me into where we're going to go today, primarily focusing on a case study, biceps and supraspinatus tendinopathy, and an agility dog. Let's see, let's make this go forward. All right, and then I have to make my window a little bit smaller. So there we go. Okay. So just as a quick anatomy overview, when we are discussing the region of the shoulder, we're specifically talking in this case about the supraspinatus, infraspinatus, and biceps tendons. And to talk about the muscle itself, so the supraspinatus muscle belly is located in the supraspinous fossa of the scapula. And that tendon does go down and insert on the greater tubercle of the humerus, which when we are looking at that, and if you, can you see my arrow, or do I need to use a pen? Might need to use a pen. Um, Laser pointer. So when we look at, so the supraspinatus muscle is coming down and the tendon comes down and inserts on the greater tubercle, and this oblique, very cartilaginous insertion does show up kind of funny when we look at it on ultrasound. So just keeping that in mind as well. And the action of our supraspinatus is going to be initiating shoulder abduction and stabilizes that shoulder joint. The infraspinatus is going to originate through the infraspinatus fossa of the scapula and then come down and land on our greater tubercle of the humerus as well. It is not shown here in this picture because we are not addressing that today, but I did want to keep it in there for completion's sake here, because this is a medial view of the shoulder. And then the biceps brachii, it originates on the supraglenoid tubercle of the scapula, which is listed right here, shown right here. And it inserts on the radial tuberosity, one part of it does, and comes down into the elbow region. And so that is important to flex the elbow and assist in shoulder flexion. So just a couple of key points here that we just want to point out in the shoulder. So since we're talking about tendinopathies, we want to talk about tendon injury. And primarily when we are looking at most of our patients, from a rehab standpoint, they're mostly going to be chronic tendinopathies, which are typically due to overuse and repetitive movements. So like an agility dog or a sports dog, they may have increased eccentric loading to an area that's not adapted. So to discuss that a little bit further, when you have a normal tendon that gets the excessive load, it's going to have a difficulty maintaining that. So it's going to create this reactive tendinopathy, which is going to potentially cause the issues that we see, the lameness and problems. If that normal tendon has been loaded appropriately and slowly over time, which rehab is fantastic for and conditioning is fantastic for, then that tendon will adapt to the load and strengthen and will be able to handle an increased load in the future. So that is why in most of our agility cases, that we do stress conditioning, particularly with eccentric loading, which is going to be that load on a stretched muscle or an elongated muscle. We also tend to see that tendinopathies can occur in areas of lack of flexibility. So in the case of biceps specifically, do note that there are quite a few animals out there when I test their bicep stretch that they actually just have a lack of flexibility. When that lack of flexibility happens, if they put too much pressure on it, too much eccentric load, it is going to stretch and rip and tear those fibers a little bit easier. So we're going to start by talking about Kaya, and she's our only case for today. And she is a 10-year-old female spayed Aussie who has been an agility dog for the majority of her life. Mom has known that she needed to probably slow her down a little bit, but Kaya lives for agility. So she presented to me in August for intermittent forelimb lameness. Owner was really unsure of which, but it had been going on since July. This was exacerbated by an indoor speedway course that was on a rubber substrate. So to talk about Speedway, which is one of our newer kind of events out there, Speedway has no jumps whatsoever, but it can be tunnels, weaves. It can primarily be those types of equipment versus having jumps, which we could potentially think is safer, better, easier. But in this situation, that just the quick change of direction, probably on a stickier rubber substrate, is what likely led to some irritation of the tendinopathy, probably already pre-existing tendinopathy. Some other histories here, because you're going to watch the video of her moving. She does have a history of a left hind lameness that has since her owner resolved. She has had some vestibular spells, which have been experientially treated with Keppra, and no diagnostics had been performed for that. She also has extreme anxiety and hypertension, so you can see her list of meds to treat those things. So here is Kaya moving, and give me 1 second. I have to listen to the video, the sound. So
always has waddles.
the downfall to any patient that's nervous, and this is one reason why I'm showing this video, is that you can see her lameness, but she is pulling on the lead. And that can alter your lameness a little bit, but you could see her little head bob there. And then you can see she's actually pacing through this gait here. So the two limbs are going forward on itself. So you can see her little head bob coming through as galloping. Okay. So basically she has an intermittent right forelimb lameness. And on her physical exam, she had bilateral biceps tendon stretch discomfort. There was a click in range of motion on her left shoulder. And I wrote this down and I don't remember exactly, but I do feel like that was actually an extension where we were getting the click. On the left side, she also had supraspinatus tendon discomfort. There was also cervical neck spasms. So at this point, I did suspect a biceps tendinopathy bilaterally. Right was worse than the left. And we chose to treat conservatively with Shockwave, which I think is absolutely not a problem whatsoever. But we did discuss if there was no response to just using Shockwave, that we would perform ultrasound, radiographs, and plus or minus PRP based on what we found. So we did use our piezo wave shockwave on bilateral biceps tendon, and I chose to use a 10 pad focused shockwave. And I did 500 pulses on each tendon weekly for 3 treatments. My instructions for the owner was to restrict her, but we had poor owner compliance on these restrictions. And the owner admitted so. So we did see some improvement. So the owner chose to go ahead with diagnostics, but that we were going to go ahead and continue with our shockwave because she was responding until we were able to get those diagnostics scheduled based on mom's finances. Okay, so when we did jump in here for our diagnostics, these are all from the right side or the more affected side, okay? So this is going to be our kind of more classic view where we are looking at the biceps coming in where the supraspinatus comes in. And really what we're seeing here as we're coming in supraspinatus is coming over the biceps. We've got quite a lot of increased diffusion within the biceps tendon sheath. There is a little artifact that is running over the supraspinatus right here, just in that picture. And I apologize for the pictures not being great. And then our biceps coming in was at our insertion and was coming in with a little bit increased diffusion on this. These are actually supraspinatus, excuse me. So a little bit of effusion also in the supraspinatus and some abnormality in the fiber pattern that we're actually seeing through here as well. Thought I had a video on one of these, but not yet. So these little sparkles that you can see, that is going to be all effusion within that tendon sheath. That has chronic inflammation there. So we did have some evidence of chronic inflammation, and the tendon fibers are not linear and they're a little bit chunky through here or increased. You can also see again here on this tendon sheath, there is increased fluid as well. Not a great picture of the supraspinatus here. And then we've got just a few more pictures that are just demonstrating more effusion and biceps tendon sheath is not looking great. I'm going to change this because I think I actually might have a picture here, but the laser pointer is not letting me do it. So there we go. So this is an motion video so that you can see whenever I am actually stretching the biceps. Let me see if I can go back to that one. Stretching the biceps, that the supraspinatus on the top is actually not moving super well against the biceps, which was indicating that we did have some adhesions between the two tendons. You can also see all of the fluid that is moving within that tendon sheath. And the chronic inflammation that I mentioned, that was in there as well. And then again, you can see it on the short axis view as well. And there is at least some space between biceps and supraspinatus tendons, which is good. So at this point, oh, we've got even a couple of more pictures. Pretty much the left side also demonstrated that we had some increase in effusion as well around the short axis of the biceps. Okay. There's our video. Again, seeing this chronic inflammation within here. And remember on the exam, there was not only was there discomfort on there, but owner actually had no idea which side was originally happening. This was originally happening on. And then this is the biceps tendon and long axis right here. Supraspinatus is actually running over the top of it. So the left side looks much better and you can see much more linear pattern than the right side. So it's very evident that both sides have a tendinopathy, but the right side was a little bit worse than the left. So at this point, what we did do was go ahead and inject with PRP it's the companion CRT machine. And I did do kind of throughout the biceps tendon because they found a couple of areas where we needed to inject it. We did inject a small amount into the biceps, the supraspinatus, and also intra-articularly. We immediately at the same event shockwaved over both the biceps and the supraspinatus tendons, but just on the right side only at this point. And that was really just meant to try and get the right side healed a little bit better, and let the left side, we did start her on medications. As you can see at the bottom, we started on carprofen to help. We did do a progressive reloading of the tendons. So remembering that the tendons do well if they have some time to adapt to the load that has been applied to them. And the first 2 weeks we did rest, and then we slowly started reloading, which we did something I call unders, which is like limbo, going under things. And we started with 10 to 12 inches. We also did some backwards walking, cookie stretches, and leash walking. And again, the carprofen really made her feel a lot better once we did start that. So to just discuss a little bit on ultrasound images of supraspinatus and biceps, and how the appearance can improve when treated with shockwave therapy. And this was done by Terry Kern and Julia Tomlinson. And after they kind of did this study, they noted that dogs with tendinopathy of biceps and supraspinatus showed significant improvement on follow-up musculoskeletal ultrasound and lameness evaluation after being treated with piezoelectric shockwave when they also were rested. So that was the key there. The clinical significance in regards to this is that biceps and supraspinatus can cause variable lameness and ultrasound appearance. Again, improving after shockwave and rest. The ultrasound scoring system and cross-sectional area assessment provided useful outcome measures for clinical cases. So in this study that they did have a scoring system that they used. So how is the shockwave actually working? So shockwaves are fast, high pressure impulses, followed by low tensile negative pressure impulse. The mechanism of action is defined as mechanical transduction, where the movement of tissue stimulates biologic processes and enhances fibroblast proliferation. And it does have anti-inflammatory effects, including modulation of nitric oxide, stimulation of neovascularization, production of lubricin, and production of growth factors. And that is when I'm teaching an owner what we're actually doing, I really hit hard on the growth factors and the anti-inflammatory effect, because I think that's something that they can understand, that I'm really trying to encourage healing of tissues by asking for the production of growth factors. So when we're using PRP and shockwave together, they complement each other very nicely. This is just another kind of effects of electrical or of shockwave, is that we've got the mechanical stimulation, which we just discussed. And you can see it does increase the cellular activity, increasing and altering the release of several different substances, increase in local blood flow. It does have a transient analgesic effect of afferent nerves, so the C fibers of pain, chronic pain, which I think is very cool. And I do think when I've used it on myself before, I could attest to that. And then it does break down calcific deposits. And that's one reason why if we do find any type of calcification in the tendon, that we would primarily like to use shockwave over that area. And that can really help. So just a couple of reviews on different publications on shockwave therapy. This one was done by Becker in 2015. And they noted that when used on 15 dogs, which not a huge amount of dogs, they used it over the shoulder, and 9 out of 9 improved or had resolved lameness 3 to 4 weeks after the last treatment. And after their long-term follow-up, 64% had continued improvement. So I thought that was very, very good. And Wang et al. In the Surgical Research Journal in 2010 showed that there was regression of osteoarthritis in the knee of rats. And I think this is best exemplified in these pictures from the rats. This is the small cutouts are going to be the cartilage and subchondral bone. The first rat is the control group. You can see the cartilage is nice and plump. In the transected ligament group is, so they took part of them and transected the ligament, and then they took the other part, transected the ligament, and performed Shockwave. And you can see that the cartilage was beaten down because there was instability in that stifle joint, whereas the one where they performed Shockwave had maintained the plumpness of the cartilage. So to me, this is a really nice visualization of what Shockwave has the potential to do for our cartilage and subchondral bone protection. So back to Kaya, we did a repeat ultrasound on her a few months later. Her lameness at this point had mostly resolved. And this one is the left shoulder, which looked good before, but you can see there's actually no adhesions at all with that going through. Again, the left shoulder still right there, really moving quite nicely. And we are absent of the sparkles, if you will, so the chronic inflammation. And then we've got biceps on this view right here. Actually has much improved linear fiber pattern. There is minimal increased diffusion on this one. And again, just a quick view of the supraspinatus, where also improvement in fiber pattern and reduction in size. So again, I did do one more just because I did have just a little bit of tenderness just at the shoulder line. And on the supraspinatus tendon, it wasn't quite as perfect as I wanted to be. So I just ended up doing one more Shockwave. I did do Adequan after that because more what I was seeing was just some evidence of some shoulder osteoarthritis after we had treated the tendons. And then we slowly increased her home exercise program and began doing some straight line sprints to hope that she could at least just get back to some type of speedway because she loves agility and lives for agility. So, unfortunately, I did lose her due to follow-up as she did have a new cardiac sign coming up. So, Mom will follow up with me once she has completed her workup. Okay, and now I'll open it to discussion and questions.
That was great, Dr. Mason. Does anybody have questions? You can put them in the chat. You can scream. You can ask. I have one of, oh, I always have at least one. So, but others first. Anybody have questions?
I was wondering if you put laser over that at all?
I did not laser her specifically. I primarily did Shockwave. And the honest opinion is that every visit was a challenge with her. She was very, very, very anxious. And she was one that I couldn't even have Mom with her because she actually got very aggressive when she was around Mom. So no, we did not laser it. We purely used Shockwave on this case with the PRP.
Well, how did you manage? Oh, so she was sedated when she got her shock.
No, she actually was not. We convinced her, but we did not use Mom. We had our own staff handling her. And I think that, she liked cookies a lot. Like she lived for cookies. And so we used a lot of treats. But she was still like, so the faster my treatment, the better. So for her to sit there for we have a class 4 laser, for her to sit there for a laser treatment that I didn't think was going to potentially work very well for her in this situation because I wanted it to be a very focused treatment. I didn't find that that was going to be the right choice for her.
No, I get that. One more question. So sometimes we don't have people who want or can afford diagnostic of musculoskeletal ultrasound.
Yeah.
So I kind of go by palpation and like a ropey feeling in these tendons. So
Yeah.
were hers feeling like extremely ropey, just, I'm
Yes.
just,
Yeah,
right,
that's
right.
a great
Uh,
question. Yeah. So I do it by feel, but I also am going to stretch them as well and see what the response is to stretch.
exactly. Yeah.
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 Uh,
So, and I primarily, like, I've always diagnosed these before I ever put them under ultrasound. But it's really trying to see if you really can get that shoulder really flexed and start extending that elbow, how far you can go.
oh,
And
yeah,
so,
I do that too. Yeah, definitely.
yeah,
Definitely.
and I'll measure the elbow angle. So I'll get the shoulder kind of as far as I can go and then measure the elbow angle and I'll compare it to the other side. Unfortunately, most of the time they are bilateral, but then you can kind of tell, like, where am I getting that spasm? Where am I getting that pull back? And then as you're treating them with whether it be shockwave or laser, you can kind of compare that angle as you go through to see if you are getting improvement with that stretch, whether it be that you're not getting the spasm, not getting the pain.
I'm
So
not
I
getting
need
the
to,
vocalizing. Yeah.
yeah, I mean, if they're vocalizing, I mean, something's probably
Oh,
torn
yeah.
pretty good.
Yeah.
Yeah. Yeah. And then sometimes all of a sudden the pain and the lameness goes away and you go to test them and they're like, "Ee," and and it's like, okay, well, you just torn your biceps all the way. And I have had that happen too. So things to kind of keep in mind. And also, it's very rare that you're going to find a biceps tendinopathy by itself with nothing else involved. So you could see in this situation, the supraspinatus was involved as well as inside the joint. So I needed to treat, and when I got the resolution, it was once I kind of started treating everything.
Yeah.
And sometimes I have to remind myself of that. The other thing is when Terry and Julia were doing their study with the piezo wave, they did note that they actually felt like the 750 pulses may have been kind of the sweet spot for them. So I have since kind of started changing a little bit of the way I do it. And so I've started doing about 750 instead of 500. I don't know how much it makes a difference, but I've started doing that.
Great. So did you use Terry and Julia's intensity? Were you at about 0.1, 0.15? Do you remember? Or 6 on your intensity on your machine, 6 to 9?
So, um, we do it to patient tolerance.
Yep.
And I don't remember what her intensity was, but I can actually very easily look it up
Oh,
because I
I
also have
in,
medical.
in this in this well, in the same vein or same regard, are you guys seeing that as they heal, or do you feel like as they heal you can apply more energy? Have you noticed that at all?
Yes.
Okay.
Yeah.
Okay.
Yeah. And our staff, because, I very rarely shockwave anything anymore unless I'm doing it after PRP. They will increase it to tolerance. So they're looking for classic signs from the patient, like maybe their heavy eye blinks, lip licks. We don't go to the point where they're really uncomfortable and wiggly. So
Mhm.
she was a little bit hard to identify. When she was sedated, I just pulled it up. When she was sedated, I did an intensity of a 6.
Yep.
And then when she was not sedated, we actually were able to do a 5.
Okay.
So pretty decent amount on her. Um, I think when we first started, let's see, she was a 4 when we first started. So,
Okay.
so not
Good.
bad. Yeah.
No, that's and I guess that's a level. The 6 is kind of the level I recommend when they're sedated. So I'm
Yeah.
happy to hear that.
Yeah.
The
Yeah.
balance, you know.
I always aim to try and get them as close to 6 as possible with that, say, what is it, the FG75, whatever. I don't ever know.
The F7G3. So
Yeah,
what you're doing is you're trying to get them to an intensity of 0.1 millijoules per millimeter squared. And that's a
yeah,
very common level that we go to for healing any soft tissue injury, like in humans and vet, it should heal at that for sure. And that's, you know, post PRP sedated, can you go too high? I have never had that happen, but it's a question I've had, you know.
yeah. Yeah, I always never know, is it the shockwave or is it a flare after giving PRP? So I always try and be, moderate in my application. So
Exactly. Good. Yeah.
yeah.
And but you do it right after. So with my horse, my horse is now, because I'm a technician, right?
Mhm.
I've started to wait the 4 or 5 days because I don't want to touch them and be in trouble for creating the flare.
I mean, if they flare, just give them a little anti-inflammatory, I mean, it sucks, but it's, if it's one leg, then it's one leg. But yeah, I mean, that's what most that's what we talked a lot about during ACVSMR this last year in Naples was really doing them at the same time. And that's both in equine and in canine. And seeing the most benefit of that. You're getting that real big boost of growth factors. And then I do follow them with Shockwave a couple weeks after that as well.
Yep. Awesome. I just get asked that, well, do I do it at the same time? Do I do it
Yep.
before? That question all the time?
Yep.
Um, so I like to say, well, this is what I've heard.
Yeah. Yeah. I mean, somebody at some point probably is going to publish something and give us some kind of literature to base it off of. But right now it's just kind of, everybody's talking to each other saying, what are we doing? And coming up
Yeah,
from
yeah.
there.
Well,
So,
and we've all discussed the literature study, and it's not easy because you need so many groups.
yeah,
Um, you know,
right. Exactly.
adding two things, you need a lot of dogs to get anything statistically
Right.
relevant.
Right.
So awesome. Any other questions, thoughts, ideas? It was a perfect review for shoulders for me too. Always practicing my shoulder anatomy, and I'm actually writing my team's shoulder review course. So great for us all.
Yeah.
Other questions, thoughts, ideas? Everybody's tired and hungry, but it was an amazing case. I love being able to, the way you were able to walk us through the ultrasounds, I think, very helpful for us, who don't get to do our own ultrasounds all the time.
Yeah.
Sometimes
And
people throw them up and they just say, this is this, and you're like, which gray line are you looking at?
yeah. And I'm still learning. I think I will forever still be learning ultrasound. And I go back and look at my images and I'm like, man, if I were just a little bit more on angle when I took that picture, that would have looked prettier. So I apologize if anything looked poor, but that's, I'm always criticizing myself on the image qualities that I'm getting. So
As long as you have a diagnosis is amazing in vet rehab, right?
right,
I
exactly.
love it. Objective diagnosis is
Yeah.
great news for us. So,
Hey,
Yeah.
can I ask a quick question? Just thinking about, I know you pinpoint an area, you get the reaction from the dog, and you wait till the reaction goes away. Do you sort of then paint over the area, moving the wand? I was just curious about your technique on how you do that.
Yeah, it's a great question. So I'm going to use my finger if you can see me and pretend like I am using what I call the pinpoint head or the F7G3, whatever. So I will kind of, if I know that I'm aiming for a very small tendon, then I will even just shift the directional versus moving the head unless the animal is like, I really can't. I don't think, and if they start wiggling a little bit, I'll just kind of paint a little bit. But I really, because I know that this is not a big tendon that I am focused on, that if I'm getting a response to that area and I can like sit on it as long as I can, I just rotate and kind of change the angle fanning more than I do paint with a brush. That's not in every single location. I will tell you there are other locations, like if I'm doing more of like myofascial, that I will do more painting of the area. And so it depends on the purpose that I'm using the shockwave on. And then I'm gonna let Cindy kind of also follow that too with what her recommendation is.
Thank
So
you.
so my recommendation is it all works.
Mhm.
And there's 100 different ways, but I want to get enough energy to the affected tissue. So you will notice that a lot of the protocols that we put out may have excessive pulses, like, and be a little longer. And that is because they were written for technicians or myself to have a little extra room to find where we need to, focus our shockwave. And then I always teach that in my head, when I find that area that they react, or I know I'm in the elbow joint, or I know I'm on the tendon lesion, that I want to kind of know I give 300 to 400 pulses on that exact tissue. And I know that anecdotally that will turn on the mechanotransduction process. Does that help at all?
Helps a lot. Thank you very much. Appreciate.
Um, I do, because we don't pay for the pulses and because I'm a technician and I will put my hands on something, and some days it's like, oh, I feel it. And other days it's like, whoa, give me. So I'd rather use more pulses and get to the right place. So that's something I recommend. And when you guys are ultrasounding or injecting, the other thing is, if your machine is technician driven, have them take pictures of where the ultrasound transducer is, or where the needle is going into the joint. Because I pull those pictures up on my phone all the time.
Yeah.
It just really helps.
Yeah.
Most of us are visual who do this, and that will be,
Yeah, and that's what we do, because we communicate with our staff on Teams, and like we'll have in our notes we want to shockwave like the origin of the sartorius or something. So we'll take a picture of exactly where we want the shockwave to be performed. And, kind of to talk about like painting, let's say this is like their shoulder, and this is like infraspinatus and supraspinatus and all that stuff. So I typically will like tell my tech, I'll say, I want you to do 500 supra, 500 biceps, maybe 500 infra, 500 medial shoulder. So instead of just like do painting and getting like all of the thing covered, like I would with maybe a class 4 laser, I'm actually being really quite specific with what I actually want to treat. And then that way that whole joint is actually getting treated throughout that process. But I'm actually giving specific like focal zones that I want them to think about whenever they're treating those.
Yeah, I love that. And the other thing, when we do talk painting or active or scanning, however you term it, most of us have used a class 4 laser. And my comparison to that is, a class 4 laser, you move centimeter to centimeter, and a piezo wave shockwave, you move millimeter by millimeter.
Yep.
So it's much slower.
Yep.
And on the pulse rate, how do you decide, 500, do we do a little more? Are you going by looking at the critters, seeing reactions, plus palpating the tissue? I mean, how do you decide? You say, you might need to do more, might do less. I'm just curious how you figure it out.
Yeah, so I typically look at like, so let me use, for example, like if I want to treat a section of like, say, L7 to S2, because I'm treating lumbosacral disease, that's a bit a larger area. I'm using usually the linear pad to do that, but that's a larger area to treat than say the biceps tendon. So I am going to ask them to use a little bit more movement with that pad. So they are going to need to, I'm going to need to prescribe larger number of pulses to hit that area, versus when I want this one focal spot. I know based on kind of anecdotally, as well as, even looking at Terry and Julia's paper that says, 750 might have been kind of their sweet spot. And I know that I want to sit on that and focus on it. And I really want to stimulate, because I'm trying to get fibers to come back together. And I want to really load that tissue as much as that patient can tolerate it. And so a lot of times I'll like say I want 500 at focal zone. And I'll even watch the patients, and I will see them when I get close to 500, they're almost like, oh, I just don't know if I can take it anymore. And I'm like, okay, I'm done. And I don't know what it is, but that just seems to be that sweet spot for piezo wave. And I've even seen that too when I even do lumbosacral and I just even sit straight. Like if sometimes I'll do the wider gap of but L7 to S1, I'll even just sit right over that disc material and I will just hit it. And I will see that patient when I even get to 500, if I'm really loading that tissue right there, I'll see them like be like, okay, now I really don't know if I can handle that now. And then I'll start like moving it a little bit and kind of helping them to tolerate it and get through it. So, and I don't have a book that says that. I know that Cindy has a book that's been written. It kind of gives you a variety of different
Ideas.
ranges, ideas. But I mean, it's also I've used it on myself, and I know when I've done too much. So like I've drained a tissue. Like I did my knee, and I did 2,000 on my knee on one spot 'cause it felt great. I hurt for 2 days. I haven't had a problem since, but I hurt for 2 days. So, like it's like I don't necessarily want my patients to be that way because then you get clients going, well, they hurt after that and they didn't do good. So I don't want to do that modality again. And I don't want that, right?
I'm actually treating my agility border collie for exactly this, which was fascinating to see it. What I'm finding, she'll start to close her eyes. I mean,
Yeah.
have you noticed that too, that they'll get to the point, she jumps on the table and she's ready to get treated.
Yeah, they love it.
Yeah, and I thought that's interesting because I've not had any other animal do that. So,
Yeah. So I have a lot of patients that'll do that. And that's why I kind of wanted to put that, diagram in there of like the C fibers of pain. So we are blunting some of this, like it makes some of that achy go away. Sometimes it makes it stir up a little bit. Like when I did too much to my knee, I was achy. I was
yeah.
achy to the bone. But it does feel good. And that's actually why I did too much on my knees because I was sitting there, I was talking to somebody and I was like, man, this like it hurts so good. Like it's like, oh my gosh, like you're like scratching that itch deep down inside my knee. So it's that feeling, I do think that the animals enjoy it. And I don't want them to get to the point where they're like bracing themselves, like, I hate this so bad. I want them to come in and be like, stand right in front of the machine and be like, yeah, make me feel better. And I will admit, I mean, I've got some cases that they're like, yeah, just make my dog feel better so they can go and run. Like I've got a couple of Westminster dogs and they're like, yeah, I just want to go like be able to get them out there and run them so that they can get ready. And I know that this muscle aches on them sometimes, so we'll just treat them right before they go and run and they feel great. Not saying that I promote that, but it does make you feel so much better that you do feel too good. So that is the other precaution I tell owners is that after they get shockwaved, I don't want them running. I usually want them going home and resting because they can do too much, tear something, have a problem.
Okay. Thank you.
Yeah, I mean, with the dosing, there's nothing simple about it, but I want you guys to do your best to communicate because if with your owners, if your owners notice things, is the caveat. But if they are sore afterwards, I recommend backing down a little bit, and if as it's healing, I think you can probably bump it up a little bit each treatment when it comes to dosing. But unfortunately, as you talk about C fibers, and I'm actually writing up a nociceptive fascia piece for the PA for our blogs and stuff. And not only does it do C fiber, I mean, first of all, C fibers and all of the pain relief, but every brain is different. Right. And so the nociceptors are all firing, but every brain is going to give us a different signal. And that's what the brain is what feels the pain. So it's a very complicated scenario. And in people, it's great. You can say on a scale of 1 to 10, what is your pain level?
Yeah.
But we can't do that. So, but I do recommend if they're sore, back down. If they're healing, you can probably go up, and that's traditionally what we have found helps.
Okay.
That helps it all.
Yes, thank you.
Awesome, great questions. Anybody else have questions? And then with these shoulder tendinopathies, you started yours weren't horrible. When did you start your exercises and your loading? I'm thinking backwards.
So I actually tried to start her exercises after I did a month, and
Mhm.
then I began kind of easy loading with her. After I did the PRP, I actually started her loading at 6 weeks. So I do it based on healing times, and once I saw how bad she actually had kind of irritated and torn some of those fibers, I wanted the PRP to do its job, and then I wanted to get through the first phases of inflammation. So she started leash walking her at 2 weeks, and then by the time we got to about 6 weeks post, then I started really starting to test it and load it a little bit more. So doing the unders under the getting them to load all of the shoulder joints right there, or shoulder muscles there, doing some backwards walking is always very easy for them. So
That's a good reference because
yeah.
that's another question we get all the time. And in the horse world, I don't know, it's easier because I grew up in the horse world, but it's like, don't trot for 8 weeks, you know?
Yeah,
Um,
at least try and get 8 to 12 weeks of minimal exercise. And it actually, in Kaya's case, she actually did really well with her exercises. It wasn't until we actually started getting her on leash walks, which you guys kind of could see in her lameness videos, where she's kind of a crazy monkey on a leash. But those leash walks is where she would start becoming lame. So I had to tell her, like, no leash walks whatsoever, but keep doing your exercises through this. And she did a lot better once I said that. So,
and no water, right? Oh, you guys don't do water, or do you do water?
no, we could do water. She didn't, mom was driving from an hour and a half away. So we actually ended up not doing any, water therapy with her. Plus with Kaya's personality, we didn't think that that was going to go super well, but
Mhm.
I would. I mean, I will tell you that in other cases, yes, I will use underwater treadmill, usually 2 weeks after I inject them with PRP.
Okay.
Or before. I'll even start them before, because I can offload the front end a little bit by increasing my water.
I think again, there's no exact dose for the shockwave, and there's return to work is based on the case, and that's a hard questions for me to
Yeah.
answer when I get these random things. So I appreciate.
Yeah. And I mean, another good way, if you don't have ultrasound to kind of judge, is if if your palpation starts to improve, start to slowly reload the tendon. But if any point during that time, your palpation and your stretch begins to get painful again, you've done too much and you need to come off of that reloading. So a lot of it is really like trial and error with these. And if, like, in this case, I kind of looked at mom and I was like, I'm blindly going into this, and unless I have imaging, I don't know how to guide you in for this girl, because she was a little bit stoic on her exams but a little bit not. And so this case specifically was the tough one, but I don't always reach for my ultrasound. If my palpation is like, I know kind of exactly what's happening, this dog is very clear with me, there is a biceps tendon tear, I'd like to do PRP, you don't want to, let's just shockwave the heck out of it. So
Perfect. Well, thank you. That was extremely informative and a great presentation. Final questions before we let everybody go home for the night? I have a Thursday night at home. Dr. Mason, as always, I greatly appreciate your time, effort, and knowledge. Thank you, everybody, for joining us. Appreciate it.
thanks for
Thank
coming.
you. Thanks.
Have a great
All right.
night.
Night.